Yeah, hi everybody. This is a supplemental recording I promised you. It's going to entail the endocrine system. I'm going to pick up where we left off, as you can just shortly see. Just going to slide down here, right? Because we were basically in this neck of the woods. Let's do this. And what we were really talking about was the start of, as you may recall, the major, what I call the big six, the major hormones for the anterior pituitary. We covered growth hormone. Most importantly, stimulates growth, builds repair, repairs fractures, builds muscle, active in growth spurts, etc., using fat as its principal energy form, which is the opposite of insulin, which does similar activities, no, not as efficiently, particularly with bone and muscle, but in general stimulates growth, but of course uses carbohydrate as its major energy source. And they oppose each other, and you have to keep that in mind. As you can see, insulin-like growth factors, but not insulin. And then you can see what they do: collagen, deposition of bone, etc., that type of stuff. And of course, the regulation based on levels and other factors that account for it are inhibitory and releasing hormones that come from the posterior pituitary. That's pretty much standard, negative feedback 101. You can see when someone's hungry, that can, there also be a stimulation of that directly or indirectly. I don't think that's that terribly relevant for our purposes at this point in time, pardon me. So you can see that, and you can look at the effects here. Very straightforward. And again, we took the giantism and acromegaly and dwarfism, and there's nothing unusual about these. Again, now that we manufacture growth hormone, it opens up a world of opportunities to utilize it, both for good, as we talked about, as performance enhancing, or rather, as for good, as for stimulating growth in individuals who would be very, very short of stature or have growth related problems, versus for bad when it's inappropriately utilized for healing. I mean, there's a point where it's important for healing. You always see that in that thing. TSH, or thyroid stimulating hormone, it specifically targets the thyroid, so it's a very limited area that it goes to. And basically, it's part of this very elegant set of controls we have for on negative feedback for thyroid. And, and effectively, it's triggered by a releasing hormone, which is indeed triggered by circulating what are called T3 and T4, which are active thyroid hormones. So rising blood levels of thyroid hormones act on both the pituitary and the hypothalamus. But the thyroid is so widespread. Everything, as you will see when we get into the thyroid gland itself, it's so vitally important to understand that everything really, the thyroid just keeps all the other systems going at the appropriate rate. It's like your body's, I call it the governor. Basically, it governs how rapidly you do things. We'll get to that in time. As you can see, it's this TSH, which is the stimulating hormone. And again, if there's high levels of thyroid hormone, we don't need it. It acts on both the pituitary and the hypothalamus, so we don't need it. Also, GHIH, effectively, if we don't have a need of growth hormone, then we probably don't have an overwhelming need at that point in time of thyroid hormone. So you can see, typically there's a lot of regulations here. And when we get to the thyroid, this is going to be really important, because it's the reason why sometimes thyroid problems historically, as per this country and in other countries currently, we have to have some observation about. ACTH, adrenal, just like thyroid, this triggers the three outer layers of the adrenal gland known as the adrenal cortex. So it's corticotropin, classically ACTH. Everybody knows that acronym when you get into medicine. Adrenal corticotropic hormone. Again, there. Keep a mind on the pigment aspect of things, because that becomes relevant when we start looking at certain diseases that are involved in adrenal cortical diseases. And I'll comment on that when we get to that. I don't know if I'll be in the context of this dictation. So, stimulates the adrenal cortex to release three different kinds of corticosteroids. There's a release hormone, and these are what's interesting, highest levels in the morning. And it's a very important clinical note. It is we release I would call our endogenous cortisone-like substances typically in whatever your morning is. And I phrase it that way. Most of us morning is morning. But if you have somebody who's working 11 to 7, he's working a midnight shift, or she's working a midnight shift, then understand their body's clock kind of flip flops. And why it is so relevant clinically, for years, we had to use a lot of steroids. We don't use them quite as much now, dealing with immunological disorders and to try to keep the immune system in check and dealing with asthma and dealing with severe allergic reactions. All of those were utilized with cortisones. We had all things like rheumatoid arthritis and lupus. We had to use large quantities of steroids. The problem is if you decrease those, and if you take someone off of them, you have to be very cautious of when to take them off. And if you have ever taken a thing called a dose pack, you'll see that the last couple of doses are in the morning. The reason is you don't want to artificially, how shall I say it? You don't want to artificially confuse the hypothalamus in the sense of once you no longer have to give them, let's say as a medication, let's say for a severe allergic reaction or for severe asthmatic reaction, you don't want to be able to basically impact your hypothalamus adversely, and all of a sudden say, "Hey, I'm not going to," well, they have plenty of, if you gave it to them at night, it's going to be circulating at night in their bloodstream, and the hypothalamus is going to say, "Hey, well, I don't have to deliver any more in the morning." So that's why we make the last dose in the morning, so they're going to diminish, relatively speaking, normally, and by the time the next morning runs around, they're going to be low levels, and the release will go as expected. And it's interesting, even in surgery, because we release cortisol is something that your body does when it's trying to heal. We Surgeons don't mind if cortisol levels are up a little bit when they're doing procedures. It's not necessarily, it does raise blood sugar, that's a problem, but it's not a big deal if you add a little extra dose in there sometimes. And this is what we used to do. I do not know how they do it now. Again, I haven't operated in 25 years. So I'm not quite sure what dealing with a patient who had steroids as a medication. So there's lots of different factors: fever, hypoglycemia, stressors. Think of those as all stressful situations when your body's being put in an at-risk situation and your adrenal cortex compensates. And the others are all gonadotropins, and they are really based on either circulating estrogen, progesterone, testosterone levels, or circulating chemicals that reflect the egg or sperm availability in your system. So, as you can see, FSH, follicles, make eggs and sperm. Luteinizing hormone, LH, produces the typical gonadal hormones. The LH also plays a role in, particularly when we get to the reproductive cycle and triggers ovulation. Maturation plays an important role in this as well. And in male, you can see it stimulates testosterone. We look at this more thoroughly. For now, this is sufficient amount to know. We do this much more in detail in repro toward the end of the term. So as we see them, they're not there in prepubescent boys and girls. It's triggered by gonadotropin releasing hormone, very famously GnRH, during and after puberty. That is suppressed, and that will basically, effectively, those gonadotropins themselves, just their very presence, suppresses their release. They almost, when those hormones are present or when they're producing estrogen, testosterone, etc., it suppresses the release of this very important releasing hormone. You're going to see down the road, again, when we get into reproductive, it's very, very interesting. And prolactin, not so terribly well understood. We know it's milk production in females. That's fairly evident. There's an inhibiting hormone, which happens to be dopamine, coincidentally enough. Not that that's that relevant. And obviously, this prevents release of prolactin until needed. So, just the very presence of dopamine, you could view it as that. Interestingly, and I'm sure they'll comment on this. I think it's in this PowerPoint. But one of the first things we learned when someone has a pituitary tumor, and they're more common than you think, one of the earliest signs is inappropriate lactation, like any lactation in a male, and in a female when there's no reason to. That's one of those little bells that goes off in the back of a clinician's head, going, "What? That's really odd. Let me see. Let's just double check and make sure we're not dealing with potentially a tumor developing or some other condition involving the pituitary. So as you can see, other things, breast swelling and tenderness, suckling stimulates blood levels rise toward the end of pregnancy, so it's associated with pregnancy and lactation. So this is more common getting extra. Hyposecretion is never a problem unless someone's going to be nursing. That hyperprolactinemia is that, and this is what the comment, pituitary beta part tumors. Clinical signs, inappropriate lactation, menstrual problems, infertility in females, impotence in males. So obviously, it certainly plays a role in reproductive physiology. The role is just not terribly well defined, would be the best way to describe it, and they're going to summarize all of these. So happy to be done with that, and we can move on.